Hi, everybody. It's Carin Andersen with Aortic for this week's Week in Review. This is really an opportunity for you to learn a little bit about the posts that we had up on our social media pages last week in the event that you're not part of Instagram or Facebook. Uh, this gives you a chance here on our Aortic Hope AHTV YouTube channel to learn right alongside of us. And before we get started, do me a favor, please click like, please click subscribe, please follow us here. It would mean the world to us. The things that we post are extremely educational. They're wide variety of interviews and educational events that would take your mind off of aortic disease. We're pretty particular about what we put on the channel, and we'd love for you to check us out and give us that thumbs up. So let's get started. I'm going to share my screen and we're going to talk about what we did last week. Okay, let's get started with Medical Monday. So this was a post from one of our med students, Ani. And if you've been following us so far for the month of May, you'll realize that we are talking about dissections this month. So here is a perfect example of a photo of basically you've got your heart, and this is the aortic valve right here. And here is an aneurysm right there, right around the root. It's a bulge inside in the outer area of the aorta, where as you can see, it is enlarged right here. This is where all that blood's flowing. And this is the actual tear. So when it's a tear, it tears into the innermost layer. There's 3 layers. So it can tear into the innermost 2 layers, and then it will come back into itself somewhere down the line. Right? So that's a tear. If it tears all the way through all 3, that would be considered a rupture. Okay, so let's talk about what a type A aortic dissection is, or a TAAD. That is going to be in the thoracic ascending coming out of the heart, thoracic meaning chest, thoracic ascending aortic dissection. This is something that's going to happen quickly. And it's going to progress quickly in nature. And that kind of means it requires immediate treatment. Usually it's going to be emergency surgery. And so while the diagnosis in and of itself can sound kind of overwhelming, understanding what this condition is and why it's so dangerous really can help patients and families make sense of the urgency. So what is a type A dissection? So we talked last week about how the aorta is the largest artery in the body. It carries the oxygenated blood. The oxygen is created from the lungs. It carries all of that blood from the heart and to the entire rest of the body. So when a dissection occurs in this extremely important vessel and it develops a tear in the inner lining of the aorta, this allows blood to kind of split those layers apart. Remember, there's only 3 of them. The inner one would be the strongest as you progress outward. So type A is the ascending aorta, strictly ascending. And this is the section that's the closest to the heart. So this is why it's one of the most dangerous locations, because several critical blood vessels branch off of the aorta. Really, in that arch, you have 3 main ones, and they supply the heart and the brain and the upper body. So ascending is very dangerous because, like a major highway, there's intersection for blood flow. So when a dissection occurs in this area, in the ascending area, it can suddenly block or reduce the blood flow to vital organs. So picture a highway with like one of the most busiest exits. And if those are the areas where you have an accident, that's going to be very problematic. So here's some of the more serious complications that can occur. You can have a stroke because the arteries that are supplying the brain, they branch off of the aortic arch. And if a dissection disrupts the blood flow there, well, then a stroke can occur. The upper limbs, you can have upper limb ischemia, which is decrease in blood flow. And that's because blood flow to the arms can be compromised, which might lead to pain. It can lead to weakness, and it can lead to an overall loss of circulation. You can also have something that's called coronary malperfusion. So the coronary arteries, which feed the heart itself, they originate from the ascending aorta. And so if a dissection blocks these arteries, that can actually trigger a heart attack or maybe even just severe heart dysfunction. An aortic rupture is when there's a weakened vessel and in the wall, and that can actually tear completely through. And that really is life-threatening. Going to cause some internal bleeding in your chest. Let's try to avoid that conversation. Aortic valve failure. This can happen common. It can be very common to occur. Let's try to say that when it's in the ascending, because a dissection can affect the aortic valve, which leads to severe leakage and could also then lead to sudden heart failure. And because in this area, complications can happen very quickly, it really often needs immediate care. A type A dissection is treated as immediate surgical emergency. Symptoms. This is all part of Think Aorta. When you are thinking about the aorta, let's say you have been diagnosed with an aneurysm, or you've been thinking about the aorta and your family, and you are aware that other people in your family have had sudden death ruled as a heart attack, but not necessarily confirmed with an autopsy, brain aneurysms, aneurysms anywhere in the aorta or other vessels. They've had a history of stroke, diabetes, heart disease. If you're aware of this and you know you have an aneurysm, or let's say you don't, because you don't have to have an aneurysm to have a dissection, a classic symptom of a dissection, classic, would be sudden severe chest pain, and it can often be described as a tearing or a ripping sensation. The pain can actually begin or move into the back or the neck or the abdomen. So one of the things we're hoping to do by sharing this with you is not to be alarmist, not to scare you. Everybody who finds out they have an aneurysm, they all say, well, what does it feel like to have a dissection? I wish I could tell you definitively, because everybody is different. I didn't have these pains that they describe above. I had a pop in my neck and then sudden loss of sensation in my arms and legs, but that came back momentarily later. What I had was this sixth sense. I knew something was wrong, something that I had never experienced before. And I think that is probably the most common sensation. People are like, this was not anything that they've ever heard of or experienced. But it doesn't necessarily have to be excruciating pain. We're sharing all of this with you to educate you, because dissections are rare, but aortic disease is much more common than you think. And if you are aware that you have some sort of family medical history, number one, you should be sharing all of this with a physician. And number two, you should be getting monitored to make sure that you don't have an enlargement. But that doesn't mean something couldn't happen. So we're just trying to give you as many tools as you can have to ace this healthcare journey, to not sit and watch and wait and be petrified every day, which I know these words mean nothing because you still will be slightly. They're just, look, the goal is, there's two main goals that Think Aorta and Aortic Hope have paired together to work on. One would be, let's try to diagnose people as being potentially at risk as soon as possible, so we can all be monitored and diagnosed when the time comes that there's an issue, and receive elective treatment options. That would be great. But in the event that you are feeling these symptoms and you have to go to an ER, we want you to know how to advocate for yourself and how to communicate and how to educate those that are in triage in the ER about your potential medical condition that's been diagnosed or your family medical history, so that they can move in a timely fashion and get you that life-saving gold standard CT scan. Okay, so some of the other symptoms that you could feel might be fainting. You could have shortness of breath. You could have weakness or numbness. You could have some trouble speaking. You might lose pulse in an arm or in a leg. More than likely, your blood pressure will be about 20 points higher and more in one side versus the other. Again, you could completely lose sensation in your legs or your arms or both. That will come back. So really, the symptoms vary because it depends on how the blood vessel is affected and exactly where on that ascending or descending, right, or abdominal, wherever your dissection occurs. Let's get to the good stuff, right? How do you fix it? What happens afterwards? All of this information is in Aortic Dissection, the Patient Guide, which was written by patients, and it's been clinically reviewed, and it's been endorsed by the highest medical societies, the Society of Thoracic Surgeons and the Society for Vascular Surgery. And you can get a copy of this book for free by going to our website, front page. The first book is Aortic Disease, the Patient Guide. Talks a lot about aneurysms and talks a lot about aortic valve issues. And then there's a whole separate book about dissections. Okay. There's also links in this YouTube video. If you look below, boop, 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 you're going to see links where you can download this book for free. We can also send you a copy for free. There's links to be able to order that. And the best part, talk to your physician. They can order a box of 25 for free. So let's get back into how do you fix it? So this is a surgical. Ascending is going to be a surgical fix, okay? When you are in the middle of surgery, you're going to be put on something called cardiopulmonary bypass. And the damaged part of the aorta is then going to be replaced with a synthetic graft called Carin graft. Depending on the situation, surgeons might also try to go in and repair your aortic valve or just address also any issues potentially with a coronary artery. The goal is simple, but it's critical. And the number one goal is restore normal blood flow and to do what you need to do quickly to prevent a rupture. So let's take a look at this. So there's a bunch of different options depending on what your surgeon does. Here we've got your traditional replacement of a graft on the ascending. This is also going to be a root repair. And I'm guessing and involving the areas before I think these are going off into coronary arteries, and this involves the arch and some branching as well. These all have names. I do not remember all the names, but you can look them up. You can go to the book and they'll tell you. Okay, so recovery. Because the surgery is not going to mean anything to you in there. It's going to mean a lot to your family and your caregivers, because this could be 5-6 hours, could be 10-12 hours. It really depends on what goes on inside, on everything that needs to be fixed and done. Recovery. Look, recovery is tough. Recovery from any kind of surgery is tough. A dissection in and of itself is really tough because it's an emergency situation, and there's really no way to prepare for something that moves very fast, and there's a lot of moving parts going on around you. So, you kind of have to be kind to yourself. And you're going to need at least a year before you're completely settled into who you are after this surgery. It can definitely take time, but there is no reason why you can't go on to live a very active, meaningful life after surgery. Long-term care typically would include pretty restrictive and strict blood pressure control, regular CT scans, echocardiograms, or an MRI, and basically lifelong follow-up with a cardiovascular specialist. Because once you have one, you can get another. Not a dissection or aneurysm. The aorta has been impacted. And so it's kind of never really 100% the same unless you have the whole entire thing repaired. Ongoing monitoring is also really, really super important, because the remaining portions, the untouched portions of the aorta, whether you dissect it or not, they really need to have some careful observation over time. There's other things mentally, emotionally, psychologically. There could be these things could be greatly impacted, and it is Mental Health Awareness Month in the month of May. And don't discount these things. Don't discount your mental health if you're in watch and wait, because that's hard. That's a hard thing. But if you have a dissection, you have to expect there could very well be a chance for PTSD or some type of impact, and don't let yourself struggle with that. You wouldn't let yourself struggle if you were having pains in your physical being. Don't let yourself struggle if there is pain in your psyche as well. So here's the bottom line. A type A dissection, it is a true surgical emergency because it affects the part of the aorta that's really responsible, again, for supplying all that oxygenated blood to the heart, to the brain, the upper body. There's a lot going on there. And without rapid treatment, complications such as a stroke or heart attack or rupture, it can become fatal very quickly. So fast diagnosis, emergency surgery saves lives. Understand the condition can really help the community and patients and families navigate a very incredibly stressful situation with a little bit more clarity. I love this post. Again, remember, you can go right to our homepage, and if you just scroll down, boom, that is your free download link for Aortic Disease, the Patient Guide, which was our second book. There's also a link in here where you can order it in bulk for the physicians, 25 copies in a box, order a hard copy, and take a survey when you read this because we give away monthly prizes if you do not choose to remain anonymous. And then here's the aortic dissection. So you've got your bulk order form and your free download here. We also have it in Spanish. So check that out. All right. Good stuff. We're moving on to Topic Tuesday, everybody. I think we've got some pictures in there. All right. Alvaro did a great job on this. This is talking about your type B. So A, ascending, B, descending or descending, right? Type B, descending. And so this occurs when a tear develops in the descending thoracic aorta, which allows blood to enter the aortic wall, just like it did on the type A. And what happens is it creates this false lumen or this false channel. Yes. And the false channel can compress the true lumen and it reduces blood flow to the critical branches. And when organs lose perfusion, malperfusion syndrome can develop. You know what? This has never happened to me before, but my puppy just came in here. So give me 1 second. I didn't hit stop because this is like real life, right? And when it's real life, things happen. All right, let's get back to what we were talking about. I have a 1-year-old lab. These things happen. All right. Okay. So when you lose your blood flow, she's popped in again. We're going to have to do this over again. Okay, everybody. Take 2 because my puppy came in and bursted down the doors and it just caused a major issue. So let's go again with Topic Tuesday. We're talking about dissection. So to this one, we're talking about type B or descending dissections. And really what happens in the descending is there's this false lumen. Okay, so picture your aorta. It's just a big garden hose. And when you tear, a part of that aorta fills up with blood. So it's like 2 tubes now, except only 1 tube is going to your organs or perfusing your organs. The other tube is going to nowhere. That's called a false lumen. And when organs lose perfusion or malperfusion, that's what happens. And that's one of the most dangerous complications of a type B, because think about the descending aorta. Now you have covered your brain and your arms with the branches on the arch. This is taking care of pretty much everything else. I mean, you've got renal arteries and femoral arteries. So you're dealing with your intestines, your stomach, all your organs, everything, kidneys, it's all being fed from arteries off of the aorta. So let's talk again about what a thoracic aneurysm is. So a type B dissection occurs when there's a tear that develops in the inner layer of the descending underneath of the diaphragm, excuse me, the descending aorta. And that allows, again, blood to enter the wall and it splits the layers apart, creating 2 channels for blood flow. A true lumen, which is getting the blood to everything, and a false lumen, which leads to nowhere land. Okay. Getting it to someplace where the true lumen, that's the normal pathway. That's what you want to see happen. So as blood continues to flow into the false lumen, it can expand and actually compress the true lumen, which is reducing blood flow then to the important branch vessels, which take the blood everywhere, like we just talked about, your stomach, your intestines, your kidneys, lower limbs. And this reduced blood flow or perfusion can actually lead to that malperfusion syndrome, causing tissue ischemia or death, and potentially life-threatening organ dysfunction. So think of the aorta like a one-way highway, okay? And suddenly a wall breaks and traffic spills into this new lane that nobody ever knew existed. The new lane, or false lumen, becomes really overcrowded with a lot of cars, and it starts pushing into the actual real lane that's on the highway, and it kind of narrows the only functioning lane. Like, you know, when cars are going down the road and one lane, you start seeing the arrow, hey, go in to the left. And cars all these people start trying to push into the actual lane and it smushes it, right? Just kind of, especially at the end when nobody wants to let it in. They just can become jammed up, basically. Cars trying to exit towards destinations, they're not getting through. All right, so let's take a look at this graphic for a second. Normal aorta, yay, normal aorta. You have your branches, nice, strong, one-way highway. Everything looks good. And then the tear occurs. This little teeny tiny little boop occurs. Little tear, healthy aortic wall. Now we have a tear. And now this tear has created two separate holes. You have this false lumen, not going anywhere, channel, and a true lumen. So when the false lumen is filling up with a lot of blood, it could compress the true lumen. This is the only space here getting blood flow to your organs. That can be very problematic, right? This is going to be an issue. So again, normal highway, a wall falls down and you've got all these cars jamming up and they start reducing the amount of room that's on the actual highway. Again, the Stanford system says we have a type A dissection, which is ascending surgical emergency. Type B becomes distal to the subclavian artery, and that involves the descending thoracic aorta. A non-A or B dissection, it's the first time I've ever heard of this, involves just the arch without ascending involvement or, I guess, descending. Type Bs are very important, though, if you think about it, because they can initially appear very stable, but can rapidly become life-threatening. And this is especially when the branch vessel perfusion is affected. So let's talk about what malperfusion syndrome is. A major complication of a type B, which usually impacts the decision when to surgically intervene, is this malperfusion syndrome. Sorry. So when the dissection flap is obstructing the branch vessels, it reduces the blood flow to the organs, right? So depending on the arteries that are actually involved, you can develop visceral malperfusion, which leads to severe abdominal pain, gut ischemia, renal malperfusion that can cause a lot of kidney pain, lower limb malperfusion, or just not getting blood flow. That can present your lower limbs with a lot of pain and cold, lack of pulse. Like this transforms an uncomplicated situation into a complicated emergency requiring rapid recognition and treatment to prevent irreversible organ damage. So how do we identify it? How do we assess it? Diagnosis typically begins with a clinical suspicion, especially in a patient that might be presenting with sudden chest, back, or abdominal pain, pulse deficits, signs of end organ ischemia. Just like a type A, the gold standard is going to be your CTA. So this is rapid visualization of the tear and the true and false lumen. You might also do lab markers like an elevated lactate, rising creatinine, physical exam, a TEE, so going down the transesophageal, doing a transesophageal echocardiography. That's really useful when there is no CTA available. When you combine all these things together, they can usually make a diagnosis one way or another. And how is it managed? Well, if it's uncomplicated or complicated by malperfusion or rupture or persistent pain, the goal is to basically reduce the stress on the aorta. That's like your first thing, and prevent any progression and restore the blood flow when vessels are compromised. So this is how it's done. If it's uncomplicated, like most tend to be in the beginning, they focus on anti-impulse therapy. So that is maintaining strict blood control, heart rate reduction, keeping people under 60 beats per minute when resting. Okay. That's usually done with IV beta blockers in the hospital, giving people adequate pain control because they did, after all, have a dissection, and close monitoring. And the strategy is really just to aim the stress on the aortic wall and prevent an extension of the dissection. Now, if it's complicated, if we're having some issues with malperfusion, then for many of those, a TVAR, not a TAVR, a TVAR is performed, and that is a thoracic endovascular aortic repair. And that works by covering the primary tear And I believe that is done with a stent graft, redirecting the flow into the true lumen, thus opening that up and promoting blood clotting in the false lumen and relieving the dynamic branch vessel obstruction and restoring organ perfusion of blood. So in some patient, restoring that blood flow alone is not necessarily enough, and there could be static obstruction, and that might then require branch vessel stenting, fenestration techniques, and surgical bypass. So this all gets very, very complicated. So after the graft, again, this is considered descending, like right there. So this is one way you go up endovascularly and you deploy a graft inside. Okay, here's a branch. So they connected it to one of the branches in the arch. Sometimes there's a subclavian or a carotid subclavian bypass that takes place because this looks like it's blocked in here. Let's get to the long-term management of a type B. There could be presence of complications like malperfusion, which we talked about, a rupture risk, refractory pain, or rapid aortic expansion often would determine the degree of urgency. Imaging surveillance, again, like a type A, you're going to have lifelong CTA or MRAs that are going to be essential in monitoring that situation. If you have an underlying aortopathy issue like a connective tissue disorder or atypical patterns such as non-A, non-B dissections, which again then limits it to the arch, it could influence potential choice and long-term strategies. And look, the ultimate goal is to not only survive the acute dissection, but to prevent future complications, okay, through careful long-term surveillance and tailored intervention. So look, it's not, and in type B, it's not just a structural disease, it's a flow disease. It is a blood flow disease. And the main danger isn't even the tear in and of itself, but it's how it disrupts the circulation and can lead to malperfusion syndrome. Recognize early symptoms, image promptly, and restore blood flow before ischemia begins and becomes irreversible. Those are key when it comes to a type B. I love that Alvaro is doing that. These are all our med students. So this is helpful to them, and it's super helpful to us that they're doing all of this research and extra homework for all of you. So hopefully you got something in a takeaway and understanding the difference between the type A and the type B. Okay, that's bringing us right to think aorta, think family. Look, I'm gonna play it straight. I often see on various pages posts that twist and turn the verbiage from the Think Aorta campaign. And that's great. I'm just happy that it's being talked about. It doesn't really matter how you slice it, how you dice it, how you mix it up. Think Aorta is two simple words that are saving so many lives. It's simple. And when a physician thinks about the aorta and they are proactive as much as possible in diagnosing individuals who might be at risk, those individuals have a great soft place to land here with Aortic Hope because we're able to provide resources and support systems and a lot of fun during this time period of watch and wait or after intervention, and they're in the recovery and management of this disease. And after a surgeon has diagnosed and saved someone's life from a dissection, they can come here as well. They can also come here as well. Think Aorta, Think Family was a concept built from the organization Think Aorta US. And it's really just that. It's think aorta, but also think about your family because aortic disease runs in families. It is much more common than you think. And when you're in doubt, you should check it out. Okay. Aortic dissections, statistically, they're rare. And I know to those of us who have had them, they don't feel so rare. They feel like a big deal. That's a different definition. Statistically rare, but aortic disease, much more common than you think. And when I say that, I mean aneurysms and I mean aortic valve disease. They're rare. But if you know about your family medical history, if you know about who passed away suddenly without true explanations via autopsy, if you know who's had high blood pressure issues, diabetes, stroke, brain aneurysms, aneurysms anywhere, detached retinas. Okay. You can share this information with your physician and they can start monitoring you earlier for hopeful diagnosis before you have an aortic dissection. And when you're in doubt, just check it out. So no matter how you say it, how you rephrase it, it's two simple words, it's still saving so many lives. So that's our Think Aorta, Think Family post. All right, May, Mental Health Awareness Month. And as part of our contribution to May, we want to talk about again what I just mentioned, our two patient guides. Okay, here you have the aortic disease, and here's the aortic dissection guide. When you're living with any aspect of aortic disease, the mental and emotional toll can feel just as heavy as the physical side. You know, I had my dissection in 2015, and just in 2025 in October, I had my elective valve replacement of my ascending graft, and a Lima to LAD bypass. It was a lot, right? I didn't know I was asleep. But it still impacts you, you know, when you have this, the unknown for the rest of your life. It's a lot of what ifs, a lot, and they are dangerous. So, one way to ease the emotional toll is to download one of these guides. There's links here, there's links everywhere. Resources, Hope Shop, front page of our website. These books are meant to help you break down the complex information in an easy to understand format and language and really help you feel more prepared and informed. And it's going to give you the confidence to ask the right questions to ace your healthcare journey, to advocate and communicate with your care team and educate them on how you're feeling and have them educate you about what's happening. It's going to also help remind you that you're not alone on this journey, because when you understand what's happening in your body, it can really help you quiet the fear and bring a sense of control. So knowledge doesn't take away everything or give you everything, but it can make you feel things in a way that's a little less overwhelming, right? And this Mental Health Awareness Month, take a step towards caring about your mind and your heart. This is one easy step, one easy way. Download your free guide today and empower your journey. So that is our Mental Health Awareness Month post, which dumps us right into a reminder, because we've been talking about how to ace your healthcare journey all month long. And there's a reason, because a big announcement is coming in June. So let's talk about, again, how to ace your healthcare journey, which is a two-way street for success. We've already talked about A, and how to advocate for yourself, how to speak up and talk about your wants and your needs as a patient or for your patient, if you're a caregiver, or if you're a physician. Speak up and advocate for your patient. And we've talked about how to speak up for your specialty if you're a physician and the treatment of others with the same disease. So let's talk a little bit about C, which is communicate. So communication is the bridge between confusion and clarity. And it's a key part in taking control of your healthcare journey. Communicate kind of equals staying connected, asking questions, and speaking up. And here's how to strengthen your communication. So you want to share your symptoms clearly. And this might mean writing these things down before a medical appointment, even small changes you're feeling. Don't discount that something you're experiencing or something in your family medical history isn't important. Just share it. Use patient portals. Make a phone call, email, ask your physician, how do you want to be reached? I have this conversation with my doctors. I make it very clear that I feel much better if I have their personal cell phone. And I know that doesn't mean I'm always going to get it, but I'm going to tell you, I've pretty much gotten it for everybody. And I don't abuse it, but I will be a much stronger, more compliant, easier to deal with patient if I know I have that. I'm not saying all of you are going to get it, but for some of my doctors, the portal just doesn't work for them. They'd rather an email to their work email. So you just got to talk about it, got to communicate. Ask questions until you feel like you fully understand. And maybe you just need a little bit of information and you're good. That's fair. I need all the information. So there's many different people. But don't forget to speak up about side effects you're having, concerns or fears. A lot of people, they take medications and they feel miserable. I'm like, how can you still feel miserable? Why haven't you shared this with your physician and asked for a change? Also, be sure to clarify what your next steps are going to be before you leave that doctor's office. I mean, this is all about communication. Again, this is going to help you have your best healthcare journey because this is not a power struggle between you and your physician. This is a power balance. Your care team wants to help, but they can only act on what they know, which is based on what you tell them. So the more open and honest your communication, the stronger the partnership and the better your outcomes. There's no such thing as a silly question when it comes to your health. Say what you're feeling, ask for what you need, and stay connected because when you communicate, you take a powerful step towards acing your healthcare journey. See what we did there? See what we did there? All right, we're still talking about this all month long before our big announcement. So think about how to ace your healthcare journey. All right, let's get right into it. Our events, as you see on our events page, mind you, this website will be changing at some point before the end of this year. All of these things in red are links to forms that you can sign up to join support group meetings, support groups. The caregivers happen twice a month, the first Saturday at 10 a.m., the second Wednesday at 10 p.m. Our times are all Eastern Standard Times. Survivors and caregivers, anybody can go. The first Tuesday at 12 p.m., the second Tuesday at 10 p.m., and the last Wednesday at 7 p.m. of every month. Canadians, you get to go the first Wednesday at 6 p.m. And bereavement is every other month, the second Thursday at 7 p.m. So we just had that in May. We're having the next one for bereavement in July. And what do we have? Today is the 17th. Okay, well, you're hearing this, it's going to be the 18th. So today, well, hopefully you watched the Q&A with Dr. Ben Udelman that I did because he's so entertaining and teaches us so much about, we discussed aortic centers, we discussed dissections, we just discussed so much and future potential surgical techniques. You definitely want to check that out. All right, we have our Ask a Doctor, which happens on Facebook. Sorry. It's with Dr. Siddharth Prakash. He is a cardiologist out of UT Houston. That happens on the 19th of this month at 6:30 p.m. If you happen to be on Facebook, you will see a pinned post with his smiling face at the top of the page. You can ask him any question you want. Just remember, it's a public page. Other people will see it. And if you'd like to ask an anonymous question, there's a link there for you to do that as well. Take everything in stride and use it as a way to help you communicate the same question to your actual own physician. Okay, it's not to replace the medical advice you receive. Okay, this Thursday is our first recorded interview with community member John Quick, who is a survivor, but also then became a therapist. And he has a Thursday show that we were doing live last year. We've tweaked the way that we do the show a little bit. And we're asking the community to sign up if you want to be a guest. And we're getting overwhelming response right now. So we're trying to get to all of you. And the goal of this show is not to provide therapy and by any means. It is to help you share your story with the community about your experiences from a psychological, emotional, mental health perspective and aortic disease. Because some people have no memory, so they have no issue. And that's interesting to me, at least. Some people have had PTSD symptoms, others just sad. Some had problems and then worked through it. And then the community wants to know, look, we're a bunch of warriors here. We love hearing. And you know why we love hearing about stories? Because they resonate with us. Sometimes they validate us. And the best is when they give us a moment to pause and think of ways to talk about what we just heard with our own doctors. So our first recorded is with our very own Molly Thomas. I'm pretty sure I've got this right. This is this Thursday, the 21st at noon. You can click on the link or you can go up to the programs tab here at the top of our website and click on Therapeutic Thursday. It'll be right there for you. We also have our spring bingo event, which is free, 10 games, one bingo card, and prizes ranging from $20 up to $50. So click here and you can register today. Qigong happening on the 24th with Kevin Songer. He is a survivor and he is just, gosh, I would love to get him on our Where Are You Now event because he has just rewritten his life. He's in his fourth year of a medical school program right now for Eastern medicine. But he's going to take us through some easy movements of Qigong. But again, if you're concerned, talk to your physician before starting. And then we have aortic athletes. Looks like I spelled this wrong. Don't read it. Aortic athletes will be interviewing Dr. Tamana Singh, and it's going to be Jack Crow and Greer Schneider. They're going to be interviewing her, discussing always an athlete, aortic disease, and return to sports. And then we have our last support group meeting of this month, and that'll have up June soon. So that is kind of everything that we have going on at Aortic Hope. I hope that you found this very informational. Please check out that interview we've got coming up this week, or was earlier today with Ben. If you missed it, you kind of really want to watch it. And yeah, that's what we've got. So please click like, click subscribe, and we'll see you here again next Monday at 3 p.m. Thanks again so much, and we will see you soon. Take care.
And now a sponsor shout out to Cook Medical, Edwards Life Sciences, and Heart Valve Voice USA. Thank you for helping Aortic Hope spread awareness in 2026.